Hello and welcome to another Rush Generations Health Education Lecture. Rush Generations and our staff is delighted to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, October 9th, 2024, and I'm Franco Samataro. I'm the program coordinator for the Shaman Senior Voices. I'll be your moderator for today's lecture, Cancer and Aging. Before I present to you the wonderful panel joining us today, I'd like to first thank Hannah Weinsman for helping with the production of this lecture, helping us manage the chat and other key aspects so that we can all have a great discussion about cancer and aging during Breast Cancer Awareness Month. As always, we're live streaming this lecture via our YouTube channel using the video platform Zoom, which allows us to host a good number of people who join us via phone. Thank you so much for joining us. For those of you on YouTube, we ask that you please use the chat function to ask questions and or to add to the discussion throughout the lecture. We will make sure that your comments and questions make it to the presenters. And for those of you listening to the discussion via phone, you will also have the opportunity at the end to unmute your audio and to ask your questions. We'd like to remind you that all the information offered here is for general informational purposes only, and to always seek additional professional advice for specific situations to your needs. Thank you. So I'd like to introduce to you Jennifer Yannick, our nurse practitioner, who manages patients in high-risk breast clinic at Midwest Center for Advanced Imaging with Rush Copley Medical Center. Jennifer has been a nurse for 27 years, and as a nurse practitioner, Jennifer is dedicated to the early identification of breast cancer, to educating patients about risk reduction strategies. Jennifer's services include assessing a patient's lifetime risk for developing breast cancer, identifying individuals at increased genetic risk for breast and other cancers, and providing genetic counseling and genetic testing resources, and communicating with patients regarding surveillance recommendations. Our other panelists today will be Hillary Knowles. Hillary is a family nurse practitioner who is the lung screening navigator for Rush Copley Medical Center. She facilitates shared decision-making visits for patients undergoing lung cancer screening, provides patients with screening results, and assists with recommendations and recommended follow-ups. And without further ado, I'd like to hand off to our first practitioner, Jennifer Yannick.
Thank you for having me today. Are you able to hear me okay?
We can, thank you.
Okay. Would you like my video on or off?
You can turn your screen on if you'd like.
No, it's okay. Okay, well, I am honored to be here today to talk to you about breast cancer screening and prevention. It's something I'm very passionate about, so I appreciate being able to help spread awareness and educate people on this topic. Next slide. The agenda for today is we're going to talk about breast cancer basics, breast cancer signs and symptoms, breast cancer screening guidelines, and breast cancer prevention. Next slide. So breast cancer basics. Next slide. Approximately 1 in 8 women will be diagnosed with breast cancer in their lifetime. Breast cancer is still one of the leading causes of death in women, only second to lung cancer. The median age of breast cancer diagnosis is 62, meaning that half of the women are diagnosed before 62 and half are diagnosed afterwards. Surprisingly enough, I don't know about in your own lives, but in my clinic and my friends and my family and other people that I see online, there does seem to be an unprecedented increase in younger age breast cancer diagnosis for unknown reasons. Women's risk of breast cancer is nearly double if she has a first-degree relative with a history of breast cancer. So a first-degree relative is like a mother, a sister, or a daughter. Approximately 15% of women who get breast cancer do have a family member diagnosed with it. Up to 10% or less of breast cancers might be linked to a genetic mutation, and that's when a gene isn't working quite properly and increases our risk for cancer that is inherited from a mother or a father. And about 85% of breast cancers occur in women who have no family history of breast cancer, and these are due to mutations that happen along the way in our life. For instance, most cancers are really kind of more sporadic or due to environmental exposures that cause changes in cells that turn to cancer. Or sometimes we just don't have a great reason why it happens, and so we're not able to really pinpoint it. And so that's really the majority of these cancer cases. Next slide. Signs and symptoms. I love this graphic because it gives really a good picture of different things to look for in the breast and the common signs and symptoms that get reported when it comes to breast issues that can lead to breast cancer. This is from Know Your Lemons. They're a great group. I highly recommend going to their website and looking at all of their wonderful education materials. But here are some of the signs and symptoms. A thickened area on the skin of the breast. A skin dimple, so where the skin of the breast kind of goes in a little bit. Any nipple crusting. Any nipple discharge as well. So any new fluid from the nipple area, whether it's clear or white or red, always report that to your provider. When the skin on the breast becomes red or hot, inflamed, that's also something to be concerned about. Skin sores that don't seem to be healing, lumps, bumps, masses, any growing vein that is becoming more visual and appearing more on the surface, any nipple inversion. Now, nipple inversion may be normal for you, so it's not such a concerning sign. But if you don't typically have an inverted nipple and all of a sudden it does turn in, that is definitely something to report. Any new size or shape of your breast, if one seems to be getting excessively bigger than the other, report any changes. And then there's something called orange peel appearance, where the skin of the breast tends to look more like an orange peel, where it gets kind of thick, kind of groovy, and a little taut. So we call that orange peel skin appearance. And then obviously any hard lump. Next slide. The next slide talks about risk factors for developing breast cancer. Some are modifiable, meaning that we can change the way we do things that will increase, better impact our breast cancer risk by decreasing it. Other things we can't change, like genetics and things like that. So we can't change that, so we need to kind of do things to modify and make up for that. The first one would be early menstruation, so getting your first period under the age of 12. Age, 40 and older. It's just natural progression and natural disease process that breast cancer happens more and more as you get older. So as you get older, you have an increased risk. Alcohol consumption, dense breast tissue. Dense breast tissue is when you have thicker tissue on the inside of your breast. We will go into more detail about that in just a little bit, but having dense tissue does increase your risk of developing breast cancer. Genes, like we talked about. Genetics is kind of a whole talk in and of itself, so I won't be able to talk much about it today. But if you have a genetic mutation, it will increase your risk for certain cancers. There are about 10 genes that are breast cancer specific. And if there's a mutation in one of them, you will have an increase for breast cancer in your lifetime. Most people are familiar with the two BRCA genes. However, again, there are lots of other genes that can impact breast cancer risk. Late childbirth, usually having your first child after age 35. Late age of menopause, usually starting menopause after age 55. Family history, having first and second degree relatives with family history of breast cancer can increase your risk. And then hormone replacement therapy, that is known to be a risk factor for developing breast cancer. Most breast cancers are driven by estrogen, and so when you supplement with estrogen, it can increase that risk. Not all breast cancers are fed by estrogen. In terms of hormone replacement therapy, you kind of have to weigh a risk-benefit analysis, because if your postmenopausal symptoms are really affecting your quality of life, Should you not take them just because you're high risk and then suffer, or should you maybe consider optional things you can do to get extra screening and monitoring that we'll talk about later? Maybe you do choose to take the hormone therapy. It's really a shared decision-making process with your provider and taking all of those risks and quality of life factors into play. Next slide. Now we'll talk about breast cancer screenings. There are many different professional organizations that have their own screening guidelines for breast cancer. Many of these guidelines have varying start and stop times with stop and start time recommendations, along with frequency, and it's really confusing because which guideline do we follow? The guidelines that your primary care provider follows may not be the same as the one as your OBGYN follows. So what we'll talk about today are the ones that we follow here at Rush Copley, and they would be from the American College of Radiology, the American Society of Breast Surgeons, and the National Comprehensive Cancer Network. They all follow a similar time frame and guidelines, and so that's what we stick with. Next slide. One of the first things that you can do to minimize your risk or just become more aware of your risk is find a personalized risk tool that measures that for you. Whenever anyone comes in for their mammogram here, their screening mammogram, they are given a risk assessment tool. There are several different risk models that help us determine that score, and one of the most recent and most popular is called the Tyrer-Cuzick model. That's the main one we use here. We do use others. But if your score goes over 20%, then you're high lifetime risk. It also lets us know if you're low or intermediate risk. And the benefit of this is it allows us to be able to tell you, can you wait until age 40 to start your screenings, or should you be starting screenings prior to that? So it's really nice to have a more personalized approach to these screenings so we know where we fall and so we can do something about it. Information gathered in these risk assessments includes personal and family history, like obviously family history of cancer, and then things like how old were you when you had your first baby, what is your height and weight, do you drink or smoke, do you take hormone replacement therapy. All of these things go under consideration in this risk model, as well as that breast tissue density. The risk model as well will tell us if someone is high mutation risk, and that is when we recommend they consider genetic testing to see if they have a gene mutation. So all of that gets assessed when you have mammograms with us. Next slide. So this is what we're looking at when we're talking about breast tissue density. There are 4 pictures here that describe the categories of breast tissue density. They're A, B, C, and D. Category A is mostly fatty tissue. It shows up mostly black on your mammogram image. Density can only be assessed on a mammogram image. You cannot tell if someone is dense by looking at them or by feeling them. You can maybe take a guess by feeling, but really the only way to assess breast tissue density is by mammography image. So category A is about 10% of women, shows up mostly black, which is really helpful to us because the things that show up that we get concerned about are white on the image. And so when your image is mostly black because you have fatty tissue, we're really able to see that white spot very well. Category B is called scattered areas of fibroglandular tissue. 40% of women are category B. And again, most of this picture on a mammogram is black. It does have some white splotches for increased areas of density. So we're still really able to see really well when a white concerning spot shows up. Category C, now we're getting into denser tissue. So category C and D are considered dense. 40% of women have category C breast tissue density, and you can see increase in density makes more white space on that image. And so if a white area of concern is going to show up, it can either be obscured or blend in with those white patches. And category D, 10% of women have extremely dense tissue like this, and you can see it's even more white and patchy. And so it's not that we can't see through this dense tissue altogether on a mammogram, especially the 3D mammograms. but it is more challenging. And so there are supplemental imaging modalities that you can use to supplement your screening mammogram that we'll talk about shortly. Next slide. So what are the screening recommendations? First of all, a screening mammogram is a test that's done for general health purposes. You do not have any breast signs or symptoms that are concerning, no breast pain, nothing that you're worried about. It's just for general screening purposes, and nothing is wrong, and so that's the main reason for it. When something is wrong, if you have a breast symptom that's concerning, or like one of those symptoms we talked about on the previous slide, you're going to want to talk to your provider about getting diagnostic imaging. The only difference is the purpose it's done. Diagnostic imaging is done when something is not quite right, or you want to have something further looked at. And so I just wanted to kind of clarify the difference between the two. For women of average risk and not dense, do not have dense breast tissue, an annual screening mammography starting at age 40 is sufficient with no need for supplemental imaging. And the preferred method of imaging is the 3D mammogram. Women with increased breast tissue density, category C or D, annual screening mammography starting at age 40, and consider supplemental imaging. We will discuss what that supplemental imaging is shortly. Women that are higher than average risk, so if you have a hereditary susceptibility from a gene mutation, so like one of those BRCA gene mutations or another gene, or you've had chest wall radiation therapy under the age of 30 for something like Hodgkin's lymphoma or something else, it makes you at higher risk. So you should start annual MRI screenings at 25, and then annual screening mammography starting at age 30. So we want to get you in sooner with imaging the breasts so we can catch anything that might be developing in the meantime, because you're at higher risk for something to start sooner. If your predicted lifetime risk on these risk models that we use is greater than 20% by any model, or you have a strong family history, annual screening mammography with the supplemental breast MRI starting between age 25 and 30 when recommended by their physician. So typically, the screening MRI can start as young as age 25. Screening mammography can as well. Some insurance companies do not allow a screening mammography under the age of 30, even if you're high risk. So at that point, we would recommend a screening MRI from 25 to 30. And then starting at 30, supplementing that screening mammogram with an MRI done 6 months later. So then every 6 months, you're getting some sort of a breast image. And our MRI is our most detailed imaging. We'll go into more detail about the MRI in just a little bit. Next slide. Women with a prior history of breast cancer greater than age 50 and they don't have dense breast tissue, an annual screening mammogram is sufficient. Women with a prior history of breast cancer at age less than 50 or over the age of 50 with dense tissue can consider the screening mammogram with the supplemental MRI imaging 6 months later. So when do we stop screening mammography? It just depends on many factors and shared decision-making with your provider. Is it 75? Is it when you have a 10-year life expectancy? I guess the question you need to ask yourself is, what are you wanting to do if something is found? If you really wouldn't do anything about it, then do you need to do the imaging? If you would do everything you can to treat whatever is found, then go ahead and continue on with your screening mammography. The American College of Radiology also does not recommend that patients forego their screening mammograms or diagnostic mammograms while pregnant or breastfeeding. However, the screening MRI may want to be deferred until a woman is near done or completed her breastfeeding, because the lactating breast can limit the sensitivity of the MRI image. Next slide. So common supplemental screenings. So first, we'll talk about digital breast tomosynthesis, which is the 3D mammogram, the automated breast ultrasound, or the ABUS, and the breast MRI. All can increase cancer detection, but none can decrease morbidity or mortality at this time, although there are limited studies. Next slide. This is 3D mammography. So when both patients come into our facility, they are given a 2D mammogram and a 3D mammogram. The 2D takes 2 images of the breast from the top and the side, and the 3D is also known as digital breast tomosynthesis, and it takes multiple images from the breast from different angles. A computer then assembles the images into cross sections or slices and gives the image. The benefit of the 3D mammogram is about 40% more cancers can be detected. There's fewer callbacks for additional imaging, and they see through dense tissue better. So you can see this picture of a cross-section of a rose. On the 2D mammogram, there's a lot of solid space, and so you're not getting a lot of detail of those rose petals and the different layers in the rose. The image on the right is the 3D mammogram image, and you can see there's just many more slices, and you're getting a lot more detail of all of the different layers of the rose. So there's just visibly, it's more detailed, and we're able to get a better image. Next slide. Next, we'll talk about the automated breast ultrasound, and this is what it looks like. It looks like a rectangular, flat kind of machine, and it will take like 2 to 4 passes on each breast to create an image. The nice thing about ultrasounds is they don't provide additional radiation because they use ultrasound waves. Next slide. So the automated breast ultrasound is recommended if you have category C or D breast tissue density. And it's useful to increase the detection of cancers. It gets a better look through those white patches that show up on the mammogram in women with dense tissue. It is not to replace the gold standard treatment or screening of the mammogram. It doesn't show everything that a mammogram does, like calcifications. And so it's used as a supplement to the mammogram and not in place of. The ABUS does a really good job of, seeing a little bit better through that denser tissue. And so used in combination with screening mammography can really be a benefit to patients with dense breast tissue. This is usually performed on the same day as your screening mammogram. We also have like a 3-month window where it is able to be done. We want it done within a 3-month window so we can compare it to the most recent mammogram and make sure no changes have taken place in the meantime. Next slide. So there are laws and legislation regarding breast tissue density. Illinois has been on the ball for a little bit now. So since 2019, they had a law that passed that women had to be notified of their breast tissue density because of those limitations that it can cause. And so the benefit of that is a lot of Illinois-based insurance plans also paid for that supplemental screening. I'd say over the years, more and more insurance plans are paying for that exam, and we are able to, have more and more people take advantage of that. More recently, just about a month ago, the FDA had the FDA National Dense Breast Reporting pass, which is pretty much the same thing, but now we're talking on a federal level, which is really important. And so now patients must have their notified of what their breast tissue density is and have their providers notified. And again, be able to be educated about the different things they can do about that density and consider additional supplemental imaging. Next slide. The breast MRI is recommended for women who have a 20% risk score or higher on our risk assessment tool. This is the picture of the breast MRI. When you have this exam, you are positioned on your stomach. So sometimes that is a benefit for people who are claustrophobic like myself. And it's just nice to not look at the tube and know that it's there, but you're kind of looking more down instead. So I kind of like that. Next slide. So the breast MRI is a powerful magnetic field. Again, another benefit is that it does not expose you to additional radiation because these magnets are what is creating the image. It has high sensitivity in detecting cancer. You do need an IV and will receive gadolinium as ID contrast. We need to contrast the breast tissue for the most appropriate image. It is not recommended if you are pregnant or breastfeeding, as we talked about earlier, just because the lactating breast does limit the sensitivity. If you have a pacemaker or other metal implants, it can be contraindicated because of the magnetic field and the metal implant. It's not recommended if you have renal function impairment because the gadolinium needs to be excreted through the kidneys. If you're severely claustrophobic or you have a severe allergy to gadolinium, so some people do have allergies to contrast dye, you may be able to consider it if you have a contrast allergy to CT scan contrast, because that is an iodine-based agent, and MRI contrast is not. So just something to kind of consider there. Next slide. For transgender patients, we do have screening guidelines as well. For transgender female patients, where they are born male and they transition to female, if they are average risk and they have not used any hormones or used hormones less than 5 years, no breast imaging is required. Those persons who are average risk, age 40 or older, with past or current hormone use of greater than or equal to 5 years, they may want to consider a screening mammogram because that hormone use is going to increase their risk of breast cancer. If they are high risk, if they've had our risk assessment and they are age 25 to 30 or older, past or current hormone use greater than or equal to 5 years, screening mammogram is usually appropriate. And then if they're high risk, 25 to 30 or older, no hormone use, or hormone use less than 5 years, screening mammogram still may be appropriate just because they are in that high risk category, even though they're not taking the hormones. Next slide. For transgender males, they were born female, they're transitioning to male. Patients with bilateral mastectomies or top surgery at any age and any risk. Breast imaging usually not appropriate. The caveat is you need to know what type of surgery they had, because top surgery does not equal mastectomies. When you have mastectomies, all of the breast tissue is removed, and so that risk is not there because there's no breast tissue. Some transgender male patients only have top surgery to still kind of form a muscular appearance of the chest. So some of the tissue is still there. So top surgery does not equal mastectomy, and we would still recommend additional imaging for these patients. Patients with a risk-reducing mammoplasty or no chest surgery, 40 years or older, and average risk, screening mammography is appropriate. Screening breast ultrasound with the ABUS is appropriate if they do have dense breast tissue as well. Patients with risk reduction mammoplasty or no chest surgery, age 25 to 30 or older, and are high risk, screening mammography is appropriate, as well as considering the supplemental breast MRI 6 months later. Next slide. Now we're going to talk about breast cancer prevention. And this is just a slide with different graphics of different things that can help us lower our risk and help prevent breast cancer. The first is to eat healthy and maintain a healthy body weight and body fat. So that always helps to decrease risk of breast cancer as well as other cancers. Avoiding smoking, limiting alcohol, regular exercise, limiting that hormone replacement therapy like we had talked about, maintaining a good body weight, breastfeeding is protective, and just watch out for any changes in your breast. Any of those changes that we talked about earlier, you're going to want to report to your provider so they can work it up and make sure everything is okay. And then just limit yourself from other environmental pollutants and exposures. Next slide. What can you do? Again, know your normal and report the changes. Everybody is different, so you want to know what is not normal for you so you know, I need to call my doctor and we need to have this worked out. Have a personalized risk assessment done between the ages of 25 and 30, and that way you can benefit from any additional screenings that you may qualify for based off of your different risk factors. Do you qualify for screenings prior to the age of 40? Again, family history is a big deal. So one of the other rules we like to follow is starting screening mammography 10 years prior to the youngest age of breast cancer diagnosis in the family. If that puts you still 40 or over, you know, that's fine. But what if that puts you younger? Then you should be getting your screening sooner. Report changes of personal and family history. So wherever you have that risk assessment done, you know, what if it didn't say you were high risk? What if it just recommended annual screening mammography for you? Report any changes so they can let you know if that change to your risk assessment made any difference and you should do anything sooner or consider a supplemental imaging. Know your risk factors and modify those that you can change. Very important, get your annual screening mammograms. It is the gold standard for breast cancer screening. Nothing replaces it. Anything else is done additionally. So that is really the gold standard that we want everyone to do at this time. Consider supplemental screening exams if you qualify for them. And then consider genetic testing to see if you carry a genetic mutation that makes you at an increased risk for certain cancers. Next slide. The other thing you can do is consider joining the WISDOM study. This stands for Women Informed to Screen Depending on Measures of Risk. So again, it's a test. It's taking a personalized approach to screening compared to annual mammography. Participants' inclusion includes identifying as female, ages 30 to 74, never been diagnosed with invasive or BCIS breast cancers, not having their breasts removed for any reason, and living in the U.S. And I included the website, https://www.thewisdomstudy.org if you're interested in joining that study. And they are just kind of doing this study to help women and help identify other risk factors and make that more personalized approach to screening mammography. Does every woman need to start screening mammography at 40? No, probably not. Some women really need to start sooner. But there are probably women that are okay to start later. But at this time, more research is needed to be able to delineate who needs what and when. And I believe that is really on the horizon and coming soon. That's it. So that is the end. I appreciate your time and your interest in my talk today.
Thank you so much for that wonderful presentation, Jennifer. I'm now going to kick it over to Hillary, who will talk to us about lung cancer screening. Hillary, are you still there with us?
Are you able to hear me?
We sure are. Thank you.
Great. Thank you. Great job, Jennifer. I'm here today to talk about lung cancer and lung cancer screening, a lesser-known screening for individuals, which is celebrated in the month of November. So next slide. Again, I'm Hillary Knowles. I'm a nurse practitioner at Rush Copley, and I'm happy to answer any questions regarding lung cancer and lung cancer screening. Next slide. So today I'm going to discuss facts and statistics, early detection through screening, once a patient is identified as having lung cancer, treatment options, as well as ways to reduce your risk for lung cancer. Next slide. Next slide. So lung cancer is the leading cause of cancer death in the United States and honestly worldwide. It does account for 1 in 5 of all cancer deaths among all races and ethnicities, male and female. Here in Illinois, we rank 32nd in the nation for new lung cancer cases, with the average individual being diagnosed between the age of 65 and 74. Next slide. Lung cancer can be considered a silent killer, as symptoms typically do not appear in the early stages of the disease. And when diagnosed late, treatment options are often less likely to be curative, and unfortunately, survival rates are lower. Here in Illinois, we are at about a 27% of lung cancer caught at early stage. Next slide. Now, some can presume that smoking is the major factor for lung cancer, and that is the case. However, we cannot forget about other exposures, such as exposures to radon gas, occupational exposures to carcinogens, such as asbestos, genetics and inheritance, as Jennifer mentioned, as well as outdoor air pollution. Because of the interactions between these exposures, the combined attributable risk for lung cancer can exceed 100%. Next slide. Now, often in early stages, lung cancer patients do not have any symptoms, but when symptoms are present, they can vary from person to person and are often easily confused with common respiratory illnesses. The most common symptom of lung cancer include cough that does not go away or gets worse over time, chest pain that is constant and often made worse by deep breathing, coughing, or laughing, arm or shoulder pain, coughing up of blood, shortness of breath, wheezing or hoarseness, infections like pneumonia or bronchitis, which do not go away or come back frequently, swelling of the face and neck, as well as loss of appetite or unexplained weight loss. Now, important to remember, these symptoms do not always mean you have lung cancer, which is why it is important to discuss any of these symptoms or findings with your healthcare provider, since they may also signal other health problems. Next slide. Next slide. So how can we screen for lung cancer? The only recommended screening test is through a low-dose computed tomography, or the low-dose CT scan. This is a special type of X-ray taking multiple pictures of the chest and lungs. A computer then combines these images into a detailed picture. The screening itself is very quick and painless, meaning no needles or dyes are used. Clothing can be left on. No need to fast or follow special instructions. And the screening, it takes about 10 minutes, with the actual scan lasting only seconds. The ultimate goal is to find disease early and to increase survival rates of lung cancer. Next slide. If you meet the following criteria, you are considered to be high risk for developing lung cancer, and yearly screening is recommended. You must be between the ages of 50 and 80, or through the age of 77 if you are a Medicare patient, a current smoker, or quit within the last 15 years, have a minimum 20-pack year smoking history, which is calculated by taking the number of packs per day smoked times the years of smoking. And finally, you must not have any signs or symptoms of lung cancer, which I previously mentioned. Next slide. For individuals who have been diagnosed with lung cancer and were treated 5 or more years ago, and you still meet the previous criteria, it is still recommended you have screening. At this time, only patients with a history of cigarette smoking are eligible. Individuals with exposure to secondhand smoke, exposure to radon, those that have been exposed to cancer-causing agents in the workplace, and individuals who are current or former users of marijuana, e-cigarettes, vaping, pipes, and cigars are at this time considered lower risk and are not eligible for screening. However, research is still ongoing as to when we can start screening for these patients. Next slide. As with all screenings, it is important to weigh the benefits and risks. Research has shown us screenings find more than 50% of lung cancers at that early stage. And when found early, more treatment options are available, thus increasing the 5-year survival rate from 18.6 to 64%. Now, with screenings, there is some risks. One risk is exposure to radiation, which compared to a typical CT scan is about 75% less. Another risk is having a false positive. These are when findings look like cancer, however, when studied further, they are not. On the other hand, an incidental finding may be seen. This is when a scan shows a finding which is medically concerning or may need follow-up testing or treatment. Undergoing these additional tests or procedures can lead to risks as well, because there's not always a way to know if a finding is cancer, slow growing, or normal. A patient might undergo follow-up tests or treatment. Finally, it is possible that cancer may be obscured or missed on your lung cancer screening, which is why yearly scans are recommended and can decrease this risk. Next slide. The United States Preventative Service Task Force issued a Category B recommendation for lung cancer screening, and as of March of 2021, Medicare expanded coverage to include individuals at risk for lung cancer. This means anyone with traditional Medicare, Medicare Advantage, Medicaid expansion, state health insurance marketplace plans, and those with large group and self-insured plans should not be charged a copay, coinsurance, or deductible for screening. Next slide. So how do you get screened? We recommend you speak to your healthcare provider about whether you are eligible for screening. This involves having a shared decision-making discussion, including what to expect from the screening process, benefits and risks, as well as anticipated follow-up. If you meet criteria, your healthcare provider will then write an order for the low-dose CT scan. Next slide. Listed here are the locations within the Rush system where CT lung screening is provided. We have location in Chicago, Oak Park, Oak Brook, Aurora, Yorkville, Naperville, and soon to be Lisle. Next slide. Next slide. For anyone who has been diagnosed with lung cancer, treatment has changed significantly in recent years. Providers are no longer treating each patient with lung cancer in the same way. Instead, they develop personalized treatment plans for each patient based on factors such as the stage of cancer, the cancer's unique characteristics, and the patient's overall health status. Traditional methods of treatment include surgery and chemotherapy, as well as radiation. Surgery works best for solid tumors which are contained in one area of the body. Most cancers diagnosed in those early stages, so 1 or 2, are removed by surgery. If the cancer has spread, unfortunately, surgery may not be the best treatment. The use of anti-cancer drugs such as chemotherapy and radiation destroy cancer cells. When these are used together, these treatments can be more effective at stopping cancer growth and/or preventing reoccurrence. In addition to traditional treatment methods, doctors are now using precision medicine to treat lung cancer, which include targeted therapy and immunotherapy. Targeted therapy is a form of medical treatment that focuses on genetic changes that are specific to cancer cells and can be used to slow cancer growth and/or kill these cells. Immunotherapy, on the other hand, is a type of treatment that helps the body's own immune system fight cancer. Immunotherapy includes treatments that work in different ways. They can boost the patient's own immune system, or they can train the immune system to attack specific cancer cells. Today, immunotherapy is often the first treatment used for patients with later stage cancers, stage 2, 3, and 4. Next slide. Next slide. So how can we reduce our risk for lung cancer? The most important thing anyone can do to prevent lung cancer is to not smoke or quit if you do. Screening for lung cancer is not a substitute for quitting smoking. For individuals who are wanting more information to help with smoking cessation, programs we use within the Rush system include Courage to Quit. This is a virtual smoking cessation group led by tobacco treatment specialists here at Rush. The Illinois Tobacco Quit Line, a free telephone counseling and information for tobacco users in over 200 languages, as well as smokefree.gov. This provides free, self-directed, around-the-clock tobacco cessation resources via text message or through their Quit Guide app. Next slide. We also can't forget about other ways to reduce your risk outside of quitting smoking. This includes avoiding secondhand smoke, so making homes and cars smoke-free. Test your home for radon. Kits can be bought via your local hardware store or obtained through your local health department. Individuals who are exposed to occupational carcinogens should follow health and safety guidelines when using these carcinogens. And finally, it is important to eat a healthy diet and be physically active. Regular exercise can help your lungs work better. Next slide. I do want to thank everybody for their time today. If anyone has any questions, feel free to call us, email us, or visit rush.edu/lung-cancer-screening. Thank you very much.
Thank you so much for that presentation. For both of you for joining us today, I'd like to at this time open up the floor to any questions from our callers or from our viewers on YouTube. I've been getting some of those questions already fed to me. So if any callers on this call now would like to unmute themselves, please press *6 and you will then be unmuted and you can ask our professionals a question. Yes, I see a caller unmuted. Are you there?
Yes, I am.
Great, welcome.
Thank you.
So did you have a question or comment?
I did not, since I haven't heard it. I was having phone problems.
Oh, no problem. I was saying for those that have any questions or comments and on the call, please press *6 to join us and be able to ask a question. So thank you for doing so. Okay, so the first question I had that came in through the chat is, will breast cancer genetic testing be covered by most insurances? Oh, you're on mute, Jennifer. There you are.
Can you hear me now?
Yes.
So really good question. So cancer genetic testing is covered by most insurance plans, including, Medicaid plans. But what they typically look for is they do follow certain guidelines. So if NCCN guidelines are met, meaning they're looking for certain criteria, whether a cancer was diagnosed under the age of 50, or you have three family members on mom's side of the family, like one side of the family with a history of breast cancer. So we're looking for certain criteria to be met for genetic testing to meet those guidelines. And when those guidelines are met, it is more likely that insurance will cover that testing. Testing has come a long way in the last 10 years. Hillary can, talk to the same thing because we both do this every day. It used to be really hard to get approved, even for women with breast cancer themselves. It used to be super expensive. It is now becoming more affordable for, it's being covered by patients with cancer, and their family members are able to consider it, and it's being covered by most of their insurance. If it's not covered by your insurance plan, depending on your situation, most of the genetic testing companies out there do have financial assistance programs where you may qualify for reduced payments. But the maximum cost for most of these companies, they do have patient-paid pricing. So their maximum out-of-pocket cost for testing to you would be $250, which, not that that's cheap, but it's definitely more achievable than it had been in the past. So to answer your question more succinctly, yes, insurance companies are paying for genetic testing, usually when the guidelines are met. And if those guidelines are not met, it is becoming more affordable for you to consider it anyways.
Wow, that's great to know. Actually, another somewhat similar question is breast tissue density something that is automatically looked at on yearly mammograms? How do I know if I need to be tested? And they also asked, is supplemental testing covered by insurance? But you did just answer part of that.
So breast tissue density is assessed on every single mammogram, and in the state of Illinois, your report since 2019 has automatically set it on your report. So if you go back to your results, like in your MyChart or anything, however you access your medical record, it should be on there. If you're not in the state of Illinois, it may not be there quite yet, but with this federal, new legislation, it should be there. It should be there now, really, because it's supposed to pass about a month ago. So start looking at your mammogram reports, because that's where it will be. It'll be listed as A, B, C, or D.
Great, thanks for that information. And it looks like a question for Hillary came in. Is an LDCT scan available if requested, or do I have to be at risk, at high risk for job or personal activity such as smoking?
Sure, that's a great question. So there is the option within the RUSH system to do a self-pay scan. So if individuals do not meet criteria, the pretty strict criteria for screening, there is the option to do a self-pay scan, which at our institution is $139. This does include the scan itself as well as the radiology reading it. So another, again, somewhat affordable option for those who are feel like they may fall out of that screening criteria and would like to have imaging done.
That's great knowledge to know. A question that could be for either of you or both of you is, if I'm genetically predisposed to cancer, having hereditary cancer predisposing syndrome, are there specific testing I should be discussing with my physician?
Yeah, so hopefully whoever did your genetic testing did some counseling and education with you, because your results report will have recommendations depending on the gene mutation on additional things that you should do for screening and monitoring or other interventions. Sometimes that can be just labs or imaging. Sometimes it can be surgery. There's lots of different things that go along with genetic predisposition to cancer. And so you definitely want to take advantage of those types of, services, because we definitely want to keep a closer eye on you because of that increased risk. We want to be able to catch something early so it's either treatable and curable or prevented altogether if that's possible. So definitely look into, or if you have a genetic counselor or whoever did your genetic testing, they would definitely be a good place to start. I'd start with them, because sometimes they are more knowledgeable than even a primary care physician is knowledgeable, like the most common parts of genetic testing, but other parts, they're not going to know the fine details about, and so start with the specialist who did that for you.
Great. I think we have time for one more. Any callers that are, again, joining us on this call today, feel free to hit *6 to unmute yourself, and you'll be able to join us on the call. And for those on our YouTube channel, please submit your questions via chat, and our moderator will be presenting those questions for you. I found that the screening information to be just super helpful, personally, just super helpful, knowing the statistics that you were sharing about Jennifer, about breast cancer predisposition, and I think just the rate of folks being higher risk if there's family genetic predisposition to it. And I had no idea that lung cancer was 1 in 5 folks were affected by that. So I think that is just a great reminder for folks to really take in those yearly checkups and continue to really be on top of our health. I see a caller's unmuted themselves.
Yes. Yes.
Yes.
Hello.
Quick question about.
Yes. I was trying to find out, how can I get the slides on lung cancer? I mean,
We will,
is there going to be a way to look at the slides? Because I'm on the phone, I dialed
yes,
in.
100%. This lecture is also being streamed on YouTube, our YouTube channel for Rush Generations. You'll be able to go there. It'll be uploaded later today or early tomorrow. We will have that available for you to take a look directly and see if there's any slides that really weren't able to follow through with us on the call. And
You said YouTube at Rush Generation?
if you just Google Rush Generations, our YouTube channel, you'll be able to follow us there and actually subscribe, because you'll be able to either, if you can't join us on a call like you're doing today, you can also join us via live on our YouTube chat for the future.
Okay, then. Thank you.
Of course. And I saw another caller that was unmuted.
Yes, to dovetail on that, does Rush do lung cancer pre-screenings for those who know that they are, they didn't smoke, but everybody around them did?
Sure. Again, if no personal history of smoking, but concern about secondhand smoke, there is the option of the self-pay. Right now, research is still ongoing for secondhand smoke, those that are vaping and using e-cigarettes. So at this point, it would be most likely best option to do a self-pay screening. You can talk to your healthcare provider about that and have a shared decision-making discussion whether or not it would be beneficial to you.
Great, thank you.
Thanks again, Hillary. Okay, I think that brings us this time. Again, I want to thank you both for this wonderful information that you shared with all of our viewers and callers today. Eye-opening, as well as some information that we should always be reminded of our screenings. So thank you. Any parting thoughts that you have for us?
No, thank you for listening.
Yeah,
thank you so much. Thank you so much. So now I'd like to remind everybody about our upcoming events through Rush Generations and programs. First is WRAP. WRAP for seniors. WRAP stands for Wellness Recovery Action Plan, and is a free program for anyone to learn skills to get well and stay well, and to make it to make life more enjoyable. This workshop will teach participants to develop a daily wellness plan, discover simple and safe strategies, and create plans for responding to stress, negative thoughts, and challenging times. The group meets once per week for 6 weeks for 1.5 hours each time. This workshop will be held in person on Wednesdays starting October 16th through December 11th from 10 a.m. to 12 p.m. at our Rush campus. Registration is required, so please call our 1-800-757-0202 to register. Next, we'll be learning to live well with chronic pain, a 6-week workshop for people living with chronic pain. Participants engage in discussions and skill-building activities to better cope with day-to-day management of chronic pain. All sessions incorporate an exercise element and strategies for medication management, pacing activity, and rest, etc. The next workshop will be held in person on Tuesday, starting October 24th through December 5th from 2:30 to 5 p.m. at our Rush campus. Registration is also required for this workshop, but please don't forget to call our 1-800-757-0202 to register today. Lastly, we want to hear from you and learn from you. Shulman Senior Voices aims to empower older adults to discuss what matters most to them as they age. It is important to share what matters to you most with your physicians and loved ones, and Shulman Senior Voices wants to hear from you. Please consider sharing your wisdom on why it is important for your healthcare team and loved ones to know your goals and wishes, what matters most to you at aging.rush.edu/Shulman/collaborate-and-connect, or scan the QR code that you see right now on the screen to record on a mobile device or smartphone. Our next lecture is Oral Health, and it will be held on Wednesday, October 24th as usual, starting at 1 p.m. We look forward to seeing you then, and thank you for joining us today. Don't forget, if you have any questions, feel free to reach out to us at 1-800-757-0202 for Rush Generations.